As Casey mentioned, my name is Nicole and I head up community over at Trusted Health. If you're not familiar, Trusted is the place for the modern nurse. We have travel assignments for nurses all across the country, and we also have a plethora of amazing assets from a podcast to blogs to events like this. We really do want to support you holistically at the bedside and beyond. And tonight, we're really excited to partner with the Wilderness Medical Society for Nursing in the Wild, our second of total events that we've done with the Wilderness Medical Society. We do have 3 more later for this year. Tonight, we're focusing on hiking injuries. So if you can go forward, Corinne, we can talk about our agenda.
All right, that sounds great. Let me see how I get control over my slides here. There we go.
All right.
All right.
I can do this part, Corinne, if you want, and then
that'd be great. Perfect.
Cool. Couple things tonight. If you have any questions, which we hope you do, and this is really important for us to interact with you as much as we can, you can ask those questions through Zoom chat, and Casey and I will filter and flow them up to Cory. This is your chance to listen, learn, and connect, and get really ready to learn about hiking injuries and then also just management in the wild. All right, and then agenda. We're going to talk about today's speaker. We have 1 instead of 2 tonight. We hope we can work with our other speaker later this year. She had a little bit of an accident, but she is doing totally fine. We're going to talk about the Wilderness Medical Society. We're going to talk about March protocol, hiking injuries, and then lastly, opportunities for wilderness nursing. And so with that, I will let Cory introduce herself.
All right, welcome. Thanks for taking the time to be with us today and listen to this presentation. So my name is Cory. You can see there it's Corrine, but nobody calls me Corrine unless I'm in trouble. So I'm a registered nurse. I've been a registered nurse for about 20 years. I have my BSN, and I also have my diploma in mountain medicine, and I'm working to finish my fellowship for the Academy of Wilderness Medicine. I also am currently getting my master's degree for my family nurse practitioner, and I run a business on the side teaching wilderness medicine here in the United States and also in Canada. So like you can see there, I go by Cory most of the time. And just a fun fact about me, I've never had a cavity in my entire life. My Instagram handle is @mountain_CK. If you ever want to reach out and shoot me some messages, I'd be glad to talk with y'all. So we'll just get started here. If I can't get this to work. Can't get the slide to go. Uh-oh, now I got to go back. There we go. Sorry about that. All right, so let's talk about the Wilderness Medical Society. So as Casey said before, we are working with in conjunction with the Wilderness Medical Society to bring you this information today. And it's really where I got my start and my interest in wilderness medicine. Back in the day, I got a flyer in the mail and I went to my first wilderness medicine conference, and now I'm here presenting to you. So it's been a really fun ride. So what you need to know about the WMS, so it's a non-for-profit that was founded in 1983. And really the mission of the WMS is to really encourage, foster, support, improve the scientific knowledge and membership for anybody really that have interest and activity in the wilderness environment. So this has just grown tremendously, and it's really just been incredible to see it grow over the last decade that I've been involved with it, of how much research has come out of this, how much knowledge has been shared. It's now got over 4,000 members worldwide, and 40 countries are affiliated with this. So it really goes back to that idea of combining your profession with your passion. So I am absolutely passionate about the outdoors. I was born and raised here in Colorado. So the Rocky Mountains are my backyard, and I get out there a lot, and accidents do happen. So that's what got me involved with it. The next slide is a bit of a busy slide. I'll get to that. I don't know why it's doing this to me. So about the WMS. So this is a bit of a busy slide, but I just put this in here to illustrate what the WMS has to offer. So as you can see listed, there's tons of educational opportunities. There's conferences that are on just dive, desert, marine, global health. There's conferences that encompass all of these topics. You have the ability to try and gain certifications in your fellowship in wilderness medicine. There's the diploma in mountain medicine, and now there's the diploma in dive and marine medicine as well. They do grants, they have partnerships to get good gear. You can get some wilderness certs and also global rescue services. So if you do have a chance, please, I encourage you all to go to the WMS.org website, take a look at what they have to offer. It's incredible. At the end of this talk, we're also going to share those links with you and give you an opportunity to join with a discount. So that's awesome as well. I apologize, my slides do not want to participate with me. All right, so let's start with the March protocol. And really, this is just kind of a different way of thinking about how we handle these emergencies. So this protocol takes the place of like your BLS or ACLS or PALS protocol that we've all really learned being in the healthcare profession. But when you're in an austere environment, you have to approach things just a little bit differently. Some of you might be familiar with this. It might be new to some others. So what do we do first, right? Scene safety is paramount when you're in an austere environment. If there's an accident of some kind, you want to make sure that you don't become a part of that scene. So before you approach that person, we all want to rush in and help. You need to look around you and assess whether or not you're going to become a part of that scenario. You don't want to be a victim as well. So there might be rock fall. There might be avalanche danger. You could be on a mountain bike and there could be a blind corner that could come around and another cyclist could, end up on top of you. So really making sure that that scene is safe before you approach that victim is key. So when we talk about the March protocol, we have to address massive hemorrhage first. If we do not get massive hemorrhage under control, we're really not going to be able to address those other things that come next. So there's no way to replace blood in the backcountry. So you need to control bleeding first. Then we're going to move on to airway, respiration, and circulation. I don't need to speak to that. You guys all know how to do that. That's in your skill set. And then the H part of this is the hypothermia and the hike helicopter portion. So we need to avoid allowing our patients to become hypo or hyperthermic, right? Because that will create another problem for us. Our goal is to have the normal thermic, and it improves patient outcomes, as we all know. The second part of this is you're immediately starting to think about your evacuation plan. Are you going to be able to hike this victim out, or are you going to have a much more coordinated effort to get them evacuated? Do you need a helicopter? Do you need a rescue team? So you're already formulating that plan in your mind as you're assessing this patient. I seriously don't know why these slides are doing this to me. All right, so we are going to go over three common topics related to hiking and hiking injuries and medical injury or medical emergencies. So just keep in mind these topics I spend typically an hour or more on discussing and lecturing on. So I'm going to just quickly have this as an overview. And then you guys would be allowed to ask me some questions later on, okay? So the first thing that we're going to talk about is dehydration. So I think all of us has probably experienced dehydration to some extent. And if you're feeling thirsty, you're already a liter to a liter and a half down. So you're already behind the 8 ball, and you really need to start getting on top of that. And then the other part of that is recognizing when others are in that same place. So we're going to divide this into 3 sections. You have mild dehydration, where you're going to see darkened urine. Mild thirst, right? We're already down 1 to 1.5 liters. Dry mouth, dry eyes, those mucous membranes are starting to dry out and you're noticing it. The moderate dehydration, you're getting even darker urine. You're obviously going to have a much more increased thirst, severely dry mucous membranes, and now you're going to start seeing systemic response. Your pulse is starting to pick up. It's rapid, it's becoming weak, so you're starting to really fight against that hypovolemia, and then you're moving into a picture where it can be severe. So once we're into that severe place, we're really, really in trouble. So we have no urine production whatsoever. We're not sweating. We have 0 tear production. And now you're going to start to see these persons have an alter in their level of consciousness. So they may become confused. They may become combative. They may just have slow thinking and decision-making ability. You can see syncopal episodes. And ultimately, this is going to progress to the point that you're going to have cardiovascular collapse and shock. And we definitely don't want to get to that point. I don't know why it's doing this. I'm so sorry, you guys. Bear with me with these slides.
Try to click a little bit slower. Give it a second after you click once. That should help. If it doesn't, Cory, I can always share them from my screen if it becomes an issue.
Okay, yeah, that might be better. So let's approach dehydration and talk about, how we regulate body temperature as well, because those two things pretty much go hand in hand, whether you're talking about just dehydration or a hyperthermic event. So, right, when our body's under stress, especially when we're in austere environments, our heart rate increases, right? We start to generate more heat. We lose a lot of energy. And heat is lost through processes, these four processes: evaporation, conduction, radiation, and convection. And then you get the dehydration picture in there, and then you start to lose fluid. And how do we lose fluid, right? There's a few processes in which we do that. It's through sweating, it's through respiration, just our breathing, we lose fluid, obviously urinating and defecating and vomiting. And I want to remind everybody that these processes occur not just in hot environments, but they occur in cold environments as well. And they can occur in like a water environment. So if you're a scuba diver, you're still losing this water. It's important to keep up with your hydration, even though it may not be as noticeable in that environment. So how do we treat dehydration? Really, the goal of treating dehydration is just getting that patient to the point, or even yourself to the point, that you're back to producing clear yellow urine. So we want to be kind of on the left side of that picture, right? We want our urine to kind of look that nice clear color. We definitely don't want to be on the right side of this picture, right? That looks like badness. So that's the goal. You know, there's all sorts of formulas out there, like how many cc's per hour per weight, all those things out there, and those formulas are really meant for intra-hospital management of dehydration. So really, just the goal is going to be to get fluids in them, to get them to the point of clear yellow urine. In conjunction with that, you have to consider giving them sodium as well, and you do want to give them energy. So you might consider having sugar in there. If we don't give them sodium in conjunction with rehydrating, we're going to continue to dilute the sodium in their bodies, and you can then see some hyponatremic events occur. And we certainly want to avoid that, because that's got a whole group of badness within that as well. And then who do we have to evacuate? So if you have a person that just really cannot absolutely keep anything down, they're not able to take in fluids, this is just going to get worse, and they have to go. Even if they're mentating okay, if they can't keep fluids down, they cannot stay in play, they got to go. And obviously you're going to evacuate anybody that's got some advanced stages of mental health stages, so changes in level of consciousness. I may have you take this over, just with the computer being like this.
Yep. So you stop sharing and I'll take care of it, Cory.
Thank you.
Yep.
Sorry about that, guys.
It always happens at least once at Zoom.
Oh, really?
Something goes wrong. Yeah. If we're gonna have a Zoom meeting or call or event, like it's something that is bound to happen. So no worries at all.
Thanks, Nicole. All right, we can do the next slide. So this is just an example, and this is put out by the World Health Organization, of an oral rehydration solution recipe. So you can just kind of keep this in mind, keep this in your back pocket. You don't have to rehydrate somebody with a commercial product like Gatorade or Pedialyte or something like that. You can actually make this yourself. Really just requires, again, like I said, that sugar. You need to include that salt, and obviously clean, potable water. All right, any questions about dehydration?
I think that you already answered the one that I saw in the chat, like how do you balance hydration with exercise-induced hyponatremia, but you kind of explained that through adding salt and sugar to what you're drinking. Don't know if we have any questions at this time. I'll give people just a second.
And there's a lot of research and data about exercise-induced hyponatremia. In fact, the last conference that we had from the WMS presented a research study on that. I think Kelly might be posting that for us.
Yep.
Right now. Yeah, so that's a great resource, and that's a great question. It comes up. Yeah.
Okay, perfect.
All right, let's move on. All right, we're just going to go over like common ankle and foot trauma. We're just going to focus on the feet. Of course, there's tons that we could talk about, but we'll just focus mainly on that since we're talking about hiking. So these are all the injuries that you can sustain or see when you're out there in the backcountry, or if you're like me, when you just trip at home. And those are going to be tendonitis, strains, sprains, dislocation, and fracture. So first, we've got to figure out what happened, right? So how did this person get injured? What was the actual mechanism of injury? Did they take a big fall? Did something hit them from the side? Did they just trip over a tree root? So what was the mechanism of injury? Is there point tenderness? And why is this important? Because it's really going to help to just let us decide what the actual injury is, because some injuries don't have point tenderness. Can they move around? Can they have appropriate range of motion? Are they not moving it at all? Do they have good CMS? Are their pulses intact? Are their pulses different in one extremity from the other? It's going to help to inform us what we might need to do. Can this patient bear weight? And why is this important? We want them to be able to self-evacuate and get themselves out of there. So we want to know if they can tolerate weight bearing. And then who needs evacuation? Who can stay and play? And who's got to go? So let's talk about tendonitis. So tendonitis is really just an inflammation of the tendons, right? And this is usually due to like a multi-day hike, long hikes, somebody who's undertrained. You have a situation where you're now carrying a bunch of weight on your back that you may or may not be trained for or be used to. And now you're putting a lot of stress on those tendons, and they get inflamed. So this can occur with or without swelling. And pain is going to be present with movement, and it's not going to really hurt this patient when they're at rest. Strains, so this is going to be a pulling or tearing of the tendons. So this may have associated bruising, it may not. If it has a significant tear, then you may see the bruising and some swelling. And this is actually going to be probably the most common injury. People tend to ignore when tendonitis starts up, and then they get into this picture of a strain. And so that's why this will be the most common injury that you'll see. And how do we treat this? And I'm sure that we've all heard of this acronym: RICE, rest, ice, compress, elevate, and minimize the use of that ankle. So that means if you have to stop for a while, even if it's just for a few hours, just to help that person get to the point that they are able to actually tolerate that weight and walk out, do that. Do that RICE, give them analgesics, anti-inflammatories, of course, are going to help this situation. If this person can walk, let them walk. If you have to get into a situation where you're carrying somebody, I'm going to tell you it's the worst thing that I've ever had to do is actually carry people out. So let them walk. You don't want to have to carry people, and assist them in any way that you can. So let's go on to sprains, and this is where we talk about our ligaments. And this is going to be divided up into 3 sections. You've got your first, second, and third degree sprains, right? So this is when the first part of it, the ligament's not torn. So there is going to be swelling and bruising in this case. These are stable, and they're going to heal on their own without intervention in a couple of weeks. Then we get further down the line, and we've got second degree tearing or sprain. And that's a partial tear of that ligament. And you will see swelling and bruising over that ligament that is torn. This can heal in about 6 weeks. It's going to be uncomfortable for that patient to continue to use that limb. But they can continue to do so and probably help to self-evacuate. This third degree, this is going to be a complete tear of this ligament. I don't know if any of you are skiers, but I've done this. I've torn my ACL, ripped it right in half, and you're going to see significant bruising, significant swelling. They're unable to bear weight, and also they're going to have an unstable joint. So this person may not actually be able to bear weight and tolerate walking out on this. This requires surgical intervention, and they're not going to be back to normal until about 6 months have passed. All right, I love this picture. It's kind of like, ugh. It's going to be your dislocation. So dislocations of the ankle are actually pretty uncommon. They're not as common as, they say, dislocations of the shoulder or fingers. It's definitely going to involve the other structures in the foot. Your vessels and your nerves are actually going to be involved with this too. And this is how we're going to decide whether or not we're going to relocate this or reduce it. It's going to obviously look deformed. No foot should ever look like that. And again, this requires a pretty massive force for this to happen. So this is a pretty big mechanism of injury, and you're likely going to have a concomitant injury with this. So you're not just looking at just this ankle, you're probably going to have other injuries that are going on with this. Very painful to this patient, obviously. They're going to present to you in a position of function. They're going to try to like hold it there because you're not going to want to move that. So that's a good key to know. If you can't really tell if it's dislocated, that's what they're going to present like. So dislocations were always very scary to me to learn, because this is not a skill that was in my wheelhouse. Obviously, as a nurse, I never got taught how to relocate anything, but I'm more and more comfortable with it. So if you're not comfortable with this, I really recommend that you watch YouTube videos, really just, get as much information as you can about this, because there is reason for you to actually try to reduce this, even if you're not good at this or it's not in your wheelhouse. If you are more than 2 hours away from definitive care, or if you have lost the pulse in an extremity, you really need to try and reduce this. That's when you want to reduce it. If I'm close, if I'm a mile in the trailhead and I don't know I can get this person in the car, I'm probably not going to try to reduce this ankle. I'm probably just going to get them to definitive care. The way in which we reduce any dislocation, most dislocations, is really by providing axial traction. And that's going to be that you're making that injury worse almost. So you're pulling that injury away from the joint, and then you're kind of pulling it up and over the talus, getting it back into place. And that's really a common way of reducing something back into place for any joint. If you're going to attempt to do this, you need to attempt to do this sooner than later. The more swelling that occurs, the longer you wait, the longer those muscles become contracted and don't release, the harder this dislocation is going to be to reduce. You really do need to make this decision pretty quickly. Attempt it again if there's a loss of pulse in the foot. These dislocations almost always have a fracture. And of course, there's no way for us to know that unless we have radiographic studies done. So you do need to get this person to definitive care so that you can get that x-ray and see if there's a fracture in there as well. Again, splint that in place. If you're going to splint, check for that good CMS and pulse before you splint. Check that good CMS and pulse after any splint's applied, and continue to check those things as you're evacuating, because you may lose pulses, you may lose sensation, and you wouldn't know that unless you were actually checking for that. Pain medication, always RICE, and get them to definitive care. So fractures. So how do we know if something's fractured, right? How can we tell if we had that dislocation that we have an involved fracture? We can't, right? Unless we really obviously know that it's a fracture. So the way that we discern fractures obviously are closed or open. When we think about open fractures, we always think, oh, that big bone that's protruding out of the skin. We know that it's a compound open fracture, right? But that's not always the case. If there's a break in skin and you suspect a fracture, you have to consider that an open fracture. And that's important when we're in an austere environment, especially for infection control and considering what we're going to do and how we're going to get them out of there. Obviously, pain, swelling, bruising is going to be, but there may or may not be noticeable deformity. So again, what are we going to do here? We're going to check for distal color movements, good CMS and pulses. If the ankle's unusable, assume that there's a fracture and splint it in place. And then we start to talk about, well, how do we splint things in place? And I'll talk about that in just a second. Provide your pain medication, check your CMS frequently. Please don't forget to do that. Keep that extremity warm. If you're going to take that sock or that shoe off of that person, you now have somebody who might get, frostbite or frost nip on that extremity. And also if they're attempting to help extract themselves out and they have the foot there that's in the upper left corner that's just open, then they might try to put their foot down if they trip or something, and then you're going to get sticks, stones, things like that go through that foot, and it's not protected. So we always discuss trying to leave that shoe on, opening it up, allowing for swelling to occur, but at least leaving that shoe in place so they've got a protective barrier there against the environment. Improvised splints. So these are SAM splints. I don't work for SAM Splint. I don't have a relationship with SAM Splint, but it's a fantastic product. It's an aluminum splint, so it's really light. I carry one in my bag all the time, and you can cut these. They come in different sizes. They can be used for any joint. They can be used for any injury, so they're really versatile. When we talk later about what to have in your bag, we talk about putting things in your bag that are versatile, that you can use for more than one thing, and thinking outside the box. If you don't have a SAM splint, what else can you use? Can you duct tape a couple of branches together or a couple of ski poles together around that injury? Shoving some t-shirts in there, really stabilizing it, because the better that you stabilize a fracture, the more comfortable the patient will be, the easier your extrication for that patient is going to be. All right, any questions on that?
Ross asked recommendations on a technique for resetting a dislocated ankle. I know we covered that, but I don't know if you could go a little bit further, or you could provide the name of it again. So
actually, at the end of this lecture, there's actually going to be a link and on the very last slide, that's got the recommendations for fracture relocation, and it goes into pretty good detail about exactly how to do that. So again, it's really, and I can demonstrate it with a finger. So if you have a finger that's dislocated, say it's dislocated sideways, right? What you do is you pull that in the direction of the dislocation. So I pull it sideways and then I flip it back over the joint, and then it goes back into place. It's really about getting that axial traction. So you're going to pull it in the axis in which it's injured in. Okay, so you're going to pull that ankle in the axis in which it's injured in, and then you're going to be able to pull that back over to get it back into its place. Because what happens when you dislocate a joint, right, is it comes out of its socket and it's basically sitting on top of itself. It doesn't matter which joint you're doing this with. So you've got to be able to overcome that angle to get it over whatever joint you have and get it back into its socket. And I hope that that helps to make sense, but please take a look at that guideline, and that's going to be there for you guys to access.
Okay, perfect. Thank you, Cory. Sarah asked, this goes back to dehydration, but since we don't have other questions, we'll go back to it. Recommendations for dehydration and using water around you. Iodine tabs, life straws.
Oh, so water disinfection is like one of my favorite lectures to give. It's another hour-long lecture, of course, so we could really go into this. And it really depends on where you're at. So it's going to depend on the watershed in which you're getting that water from. And I always am on the side of 2 is 1, 1 is none. And I'll talk about that a little bit later. That's kind of a survival saying. I use 2 techniques. I use a SteriPen, and then I also boil, because that's going to basically kill everything. Filters are limited because they don't do viruses. Their micron sheath is basically down to, I think, 0.02 or 0.01, and viruses can be 0.001. So those viruses can get through those water filters. So if you're in a watershed that has virus in it, you're not going to be able to filter out that virus. But most of those water filters will actually filter everything else out. They have their limitations. If you push too hard through them, you're going to push those pathogens through that filter. They get dirty, they get clogged, so they're limited. Just like iodine, halogens don't kill protozoa. So if you're in a watershed that's got cryptosporidium in it, it doesn't kill protozoa. So you've got to use something else other than the halogen. SteriPens kill bacteria, viruses, and protozoa, which is why it's my go-to. So yeah, it's a great question. If you go to the CDC, you can look at the recommendations for water filtration, and the recommendations for water filtration are done by the same gentleman that wrote the chapter in the book for wilderness medicine. So it's the same information. Again, it's also available to you on the wilderness medicine website as well.
Awesome. Thank you, Cory. So Alexandria asked, this is a great question. Talking about things that are outside one's wheelhouse, what about liability?
Again, that's a great question, and another hour-long lecture. It really is, it really depends. And the answer to a lot of questions in wilderness medicine is it depends. So if you are the medical provider, you are designated as the medical provider, you are already in a legal relationship with the people on your group, and you are obligated to provide care to your level, to your skill level, reasonable care that somebody in your position would give. And that's really what comes down to the liability. Did you render aid that was reasonable and that someone with your same skill level would render to somebody else? When I'm teaching WOOFer students, these are kids that have zero healthcare background, I teach them to render aid to that level. And I always tell them, you can't render aid to my level. You can't give out medications in the way that I can. You can't do those things. So that liability question is a great question. It talks about, you know, where is the duty? Are you in a relationship that you have to give that aid? Most Good Samaritan laws, especially in the United States, are going to cover you on the rendering aid. I know that when you're in certain states, if you actually have a sticker on your car that says that you are an EMT or you're a provider of some kind, and you drive past an emergency or an accident, you can get fined for that because you didn't stop to render aid because you're expected to. So it's state to state, and really you're going to be probably covered. I hope that has helped.
That explained it really well. Thank you, Cory. Let's see, just to call it out, Kelly shared that the WMS membership also includes a $50,000 medical professional liability policy with no deductible, which is fantastic.
Awesome.
Absolutely. All right. Well, I think we're done with questions there, and we can head on to the next section.
All right. All right. All right. So let's talk about hypothermia. I get in this situation a bit living in Colorado and doing some of the cold sports that I do. And I've definitely been hypothermic. Probably most of you have at some point in time too. So really important, hypothermia can change the outcomes of our patients once they get into the hospital. It's a really big deal that we try and keep our patients normothermic and obviously keep them going into a place where they're so hypothermic that they succumb to this. So hypothermia can occur at any temperature in any environment. I have been on river rafting trips where it's 100 degrees out and we've got somebody who's wet and they've been in the shade all day and now they're hypothermic and we can't get them warmed up. And this has actually been, we helicopter evacuated somebody for this on a hot day. So I really want you all to make sure that you continue to think about hypothermia even in hot environments. Scuba diving is one of those ones where you get hypothermic on these really nice hot days. It happens anytime. Again, these ideas of conduction, convection, radiation, evaporation come into play. It's how we lose heat into the environments. And then we start to talk about what is hypothermia, and we're going to classify these things and talk about each of them, how to treat them. So hypothermia is classified of a body temperature less than 95 degrees, right? And what contributes to this? We aren't insulated. We didn't bring enough layers. We have wet layers next to our skin. It's that guy that's on the scuba diving boat that left his wetsuit on. Now the boat is going back in and he's shivering because he's evaporating his heat. Drugs and alcohol, we get our skin vasodilates and we start to lose heat into the environment and we don't even notice that. And of course, obviously illness states as well. So let's talk about mild hypothermia first. So this is a core body temperature that's 90 to 95 degrees Fahrenheit. This patient is going to be uncontrollably and maybe even violently shivering. You're going to see vasoconstriction of the extremities. Those extremities are going to look pale likely. They could even look a little dusky and bluish because the body is trying to shut down the periphery to shunt that heat to the core to keep those organs stable. This person probably will have fine motor skill impairment. I know that when I've been out ice climbing, I start to not be able to manipulate the rope or hold on to ice axes. And that's where I'm starting to lose that fine motor skill. Mental changes can start to occur once you start getting lower and lower. This person can be confused, poor judgment, and slow decision-making. Once you start seeing that slow decision-making, it can be very subtle, but you really need to be thinking about, oh, I'm recognizing this. I need to jump on this and get this person warmed up. And you'll also have an increase in vital signs, right? Some tachycardia, tachypnea, and their blood pressure might actually be up at this stage. Moderate hypothermia is characterized by a body core temperature lower than 90 degrees, and 82 to 90 degrees is where this class is. This person, once they get lower and lower, they're going to stop shivering, and then this gets really scary. So they've stopped shivering because the body doesn't want to expend that energy. It's going to reserve that energy to keep those organs alive. And so now we're really in trouble. These patients will have a decrease in their vital signs. They will start to become, the heart rate is going to start to go down. They will get bradycardic. They will start to breathe a lot slower, and their pulses may not be detectable. So this is when we're in a big problem. They'll have a decrease in level of consciousness to the point that they can become somnolent and unarousable. And this is a key point here. Once we start getting into these lower temperatures, cardiac dysrhythmias can be triggered just by subtle movement. So it's really important to know that, because if you're going to extract somebody or help to get somebody out of this situation, that you're very cautious in their evacuation. Paradoxical undressing is due to the vasodilation. I don't know if any of you have heard these stories where these mountain climbers have been lost on the mountain and they go up to retrieve them. And once they have gotten to them, they've taken off their snowsuits and they found them half naked. And it used to be a long time ago that they thought that these climbers basically did this in a suicidal effort to speed up their death because they knew that they weren't going to make it. But it's actually this paradoxical undressing due to that vasodilation. Now we'll talk about some severe hypothermia. So we've got a body core temperature down to 75 degrees. This patient's going to be comatose, muscle rigidity, fixed and dilated pupils, severe bradycardia that's difficult to detect. So this patient may still actually have a heartbeat, and you may not be able to detect it unless you're feeling for that pulse for several minutes. So they may have a pulse rate, that's 10. But it's important that you spend the time and look for that pulse. Apneic, of course, and sensitive again to this deadly cardiac dysrhythmia. This myocardium gets incredibly irritable, and even just picking them up and moving them just slightly can kick off, a ventricular arrhythmia. And then we have profound hypothermia. So that's that core body temperature below 75 degrees. This is likely not survivable, and this patient will present with no detectable vital signs. Now, having said that, there is a fantastic story of a woman that it's a well-known story. She was a 29-year-old female. She was out cross-country skiing alone. She fell face first into a stream. And once she was found, obviously she was pulseless and apneic. It took them 130 minutes to get her to the hospital, and they did 90 minutes of CPR en route. She was started on cardiopulmonary bypass 40 minutes into her arrival at the hospital, and she coded a couple of times, but within 15 minutes on the cardiopulmonary bypass, she regained her vital signs. 28 days later, she was discharged from the hospital, and she went on to become and practice as a physician. So they're not dead again until they're warm and dead. How do we treat this, right? Remove them from the elements, obviously. If we can get them out of that whipping rain or snow or sleet or what have you, get them out of the water, get that wet clothing off of them. That's just going to make them further lose body heat. You may, in mild alone only, submerge their extremities in warm water to help them warm up, but you want to avoid submerging them in warm water altogether, full body. Don't go throwing them in a hot bathtub or or a hot tub or anything like that, because what's going to happen is you're going to have this massive vasodilation event, and then they're going to have cardiovascular collapse and go into shock and possibly, code on you. So don't throw them in water all the way. Obviously, apply warm packs to those AV sites. That's going to be your carotids. That's going to be your groin, underneath the knees and the axilla. That's going to help to heat them up. So if you have a water bottle with you, you can put warm water in that. And if you can go back just one for me, put warm water in that, and then make sure that if you are using those hot packs, like some of us have those hot packs, don't apply that directly to the skin, because you can get chemical or thermal burns. So you want to make sure that you have a barrier between those. If this patient is awake enough and not into that moderate to severe hypothermia, you can get them up and move them around, get them up and get that body heat building. And you need to definitely supply these patients with calories, because this is a huge metabolic demand. This body's working really hard to create heat and energy. So make sure you give them some sugar and something to eat. All right, so for moderate, so this is where we're going to start doing those active rewarming interventions. Skin to skin contact is great for these patients, because they're just going to suck that heat right off of that person. In the hypothermia guideline that's later, you can look that up. In fact, I think I have a copy of it. Oh, no, I don't. You need to familiarize yourself with how to make a hypothermia wrap. This hypothermia wrap is all over the literature. It's going to help you get these patients warmed up. It works. You can get those, those warm water bottles. You can put those on those AV points, get in there with that patient, warm them up, and get in that hypothermia wrap, and it's going to make all the difference in the world. You're going to continue to have this patient lying flat, because if you're moving them around, they could have those ventricular arrhythmias. Don't leave this patient alone if they have any change in their level of consciousness, even if they're just kind of like a little bit goofy. What's going to happen? You're going to leave them alone. They continue to get further hypothermic. You come back to them and they're obtunded, and now you're in a worse scenario. This patient needs to be evacuated if you cannot return them to normal. And then severe hypothermia, again, active rewarming measures have to be taken. Cautious movement of this patient, as I discussed before, and this patient's got to get to definitive care. Right. So how do we prevent, right? The key in wilderness medicine for almost everything that we talk about, we teach, we research is prevent it from happening so we don't have to do all this intervention, right? Know the conditions before you go. Make sure that you're talking or looking up the weather patterns for that time of year that you're planning that trip. Make sure that you know that if you're going to a high alpine environment, that you need to be off of that mountain by 11 o'clock in the morning here in Colorado, or you're going to get hit by lightning. It snows here in Colorado in July. I have a story where I summited a peak here in July. I was coming off that peak with a couple of friends. It was dusk. We came up across this girl, and I thought that it was a joke because it actually was somebody that was teaching wilderness medicine and having me work for him. And I thought he staged this person, but he didn't. She was holding her ankle. She had on a t-shirt and shorts, and she had half a bottle of water with her, and it was dusk and she was alone. She'd broken her ankle. The trail was too narrow for us to actually do like a 2-person carry. So we each had to piggyback her 4 miles back to the trailhead. By the time we got there, it was dark. It was 30 degrees and it was snowing like crazy, and it was July. So had we not come across her, I think her outcome might have been a lot different. So know where you're going, do your research, bring extra layers. I always bring extra layers. Invariably, I'm gonna get cold no matter what. And it might be because I was sweating and now I have evaporative heat loss and now I'm cold. I always bring extra layers. Provide dry clothing to that person, shelter if you can. Know how to build a fire. I think that we've all been taught how to build a fire, but how many of you actually go out and practice this skill to where you have it down? How many of you can do it in the snow? How many of you can build a fire in wet conditions? Do you know how to use a fire starter? If you don't practice this and you need this skill in a life-saving emergency, this is going to be something that you're going to be very disappointed that you didn't spend time. So I just go out there and practice that. Again, familiarize yourself with recognizing that hypothermia. Recognize those signs and symptoms when they're in the mild phase so that we don't actually go down that gamut till we get to that moderate and to that severe place. All right, questions?
All right, I know we have a couple. Erica asked, would you be worried about triggering cardiac arrhythmias by doing CPR?
So this is a great question. Obviously, if you need to provide CPR, you have to provide CPR. It's not like you can just be like, oh, I think I'm going to forego this and just, hope for the best. Obviously, rendering aid means that if you don't have pulses, you have to give CPR. Yes, there is a possibility that you are going to have a cardiac dysrhythmia, but there's really nothing that you can do about it. You're in the wilderness environment. You don't have your toolkit with you. You're not in the hospital. Do whatever you can do. Great question.
Okay, perfect. Thank you. Ross asked, I have heard that skin to skin has recently been frowned upon due to the risk of having 2 hypothermic patients. Curious to hear what your thoughts are.
So I have heard this too, because you don't want that other person losing so much heat that they're actually going to put themselves in a position of now becoming a second victim, right? So skin to skin it still works. I think it needs to be taught to people who are people like ourselves. We're medical providers, and we can start to recognize when it's going to be a situation where we might have 2 victims, right? So if I'm the healthcare provider, I climb into that bag with that person, and now I start to notice that I'm getting hypothermic, I know well enough the dangers of that, and I'm probably going to take myself out of that situation. I think teaching lay people that is, it can be dangerous and it can be ill-advised. So I have heard those recommendations that you're speaking of, but I think us as medical personnel and healthcare providers, I think we're more easy to detect and know when we're going to be getting ourselves or others into a bad situation. But yeah, that's a good question.
Thank you. Lauren asked, can you touch on after drop?
After drop. So this is a phenomenon that occurs when you take that patient out of the environment they're in. We have seen this in like a submersion type of injury. So you pull that patient out and they actually continue to still cool. So this is the after drop phenomenon, and they'll still cool and keep going. So what happens with the after drop, and I can't really give you the pathophysiology behind that. I'm sorry, I can't explain that. But they'll continue to actually drop their temperature to the point that they might actually progress from moderate hypothermia to severe hypothermia, where you think that they're good to go. You're giving them warm fluids, they're in dry clothing, you've got blankets on them, they're sitting by the fire. Next thing you know, you look over and they're unconscious and you're like, wait a second, what happened? And that's the after drop. If you have a chance to go online, you can watch, I recommend that you do this, watch these videos posted by Dr. Popsicle. So he has done a lot of research on hypothermia and how to get yourself out of like a frozen lake if you get trapped under, if you break through the ice. Basically, he shows you how to rescue yourself and get yourself out. And then you can watch him go through full on after drop, and he talks about the pathophysiology behind that. So it's a really interesting video to watch. He's been on a lot of different TV shows. I think he's kind of a total kook, but he's actually done a lot of research and really helped us understand that. So it's a great video to watch.
Okay, perfect. I'll have to look that one up.
I think his name is Gordon.
Yeah, Kelly Shortett.
Okay, yeah.
Gordon G. Gaysbrick.
Yes.
I don't know.
Yeah.
Something like that. Okay.
Dr. Popsicle.
That's easier for me to pronounce.
It's Giesbrecht, and he also has a program you can look up. It's called Baby It's Cold Outside, and it's actually a training session, set of classes.
Yeah, that's great. Yeah, thanks.
Perfect. Well, thank you for that. He sounds like a fun guy, honestly. Let's see. We have one other question, and then we'll probably need to move on to the last bit. Lauren also asked about the ability to do intermittent CPR in hypothermia during evacuation. If you can touch upon the ability to do intermittent CPR in hypothermia during evacuation.
I guess I don't really understand the question.
Lauren, if you want to.
Yeah. So I was told, like, so normally you don't interrupt CPR once it's been started, you know, more than 10 seconds for a pulse check kind of thing. But I've heard that if someone's hypothermic, that it's okay to actually do intermittent CPR in order to continue with evacuation. It still has better outcomes than like doing no CPR at all or trying to do it continuously and delaying evacuation.
I think that that's probably the case in any evacuation scenario. As long as you're trying to get them out to definitive care and you have to interrupt your evacuation, you know, you have to do what you have to do. I don't know specifically the data surrounding hypothermia per se and CPR outcomes in intermittent CPR. So that's something I can't answer that. I just would say you got to do the best you can and get them to definitive care. And if that means that you have to interrupt that CPR for you know, a minute to 2 minutes to do what you need to do, then, you know, you have to do what you have to do.
Okay. Thank you. That's a good answer. Thanks, Cory. Well, I think we're probably ready to move on. Oh, yep, to the next section.
All right. So this question I get asked all the time, and this has, you know, been the topic of discussion for hours and hours on end. Like, what do you have in your packet? What do you have in your packet? What do you take? What do you take? And as I touched on before, the answer is, it depends, right? So it depends on where you're going, how long you're going, what's the environment going to be like, how many people are coming with you, how long is the trip going to be? So, right, it depends. So when I start to talk about this, and like I said, this is just kind of an overview, and I wish I could just like break my entire kit out and show it to you. We're just going to kind of talk about where I group things. And what I do is I group things into survival, and then I group things into medical kit. So I'll just kind of talk about those two things. So what are we going to consider? So I always have a fire starter of some kind in my kit that I can get to. And I practice with it. So if you have a fire starter and you've never used it before and you don't know how to use it, then it's not going to do you a whole heck of a lot of good. I keep my fire starter with, what I do is I have cotton balls that I will sit down, like, you know, a couple nights before my trip. I take the cotton balls and I soak them in petroleum jelly, and then I fold them up into little squares of tin foil, and then I probably put about 10 of those in with my starter, because my starter will light that petroleum jelly, and now I have a fire starter in my kit that's going to help to light my other flammables. So yeah, fire starter, signaling device. I always have a signaling mirror that actually lives in my medical kit because it helps to protect it from getting broken. Again, if you don't know how to use a signaling mirror, then what good is it going to do? So learn how to use the things that you buy. It's cool to have all this gear, right? But it's not cool if you don't know how to use it. I always have a compass with me. My compass typically looks like the one that's in that picture. It's also got that signaling mirror in it as well. So I know how to actually signal somebody from afar. Navigation efforts, of course, we have a compass. I have a thing called a DeLorme, and that's a beacon, and it's also an emergency activation device. People, I think, have other devices called the Spot, things like that. Do your research on the one that's going to work best for you. Going to other countries, some countries actually help to provide an emergency locator beacon. When I lived in another country for a while, and I would stop at the local visiting like visitor center when I was entering the wilderness, and you could rent a signaling device for $15, and then you just bring it back to that visitor center at the end. So those are possibilities too. You don't just have to own those devices. Emergency shelter and blanket. There's an emergency blanket in my medical kit, and I always carry one of those emergency bivy sacks with me as well. I have had to use it before. And I'm sure it saved my life, but yeah, it's something that's light, easy, can be shoved at the bottom of my bag. Extra food and water. I cannot stress this enough. You have to have some extra food with you. You're out in the austere environment. No matter what, even if everything goes well, you're still using a lot more energy than you think or have planned for. Then if you get stuck out there for an extra day, 2 days, 3 days, you got to have that extra food with you. Extra water is more difficult to carry. Obviously, it's very heavy. So that means you need to have a way to treat your water. We kind of touched on that before. Like I said, I carry my handy dandy SteriPen that's down there in that right-hand corner. It's got its limitations. It's made of glass. It can break easily. Some of them are battery operated. I was on top of a mountain up in Washington in the Cascades, and my battery stopped working because it got too cold. So now they come with the ability to actually be solar recharged. So I have my little solar charger one now that I use. So it's just a matter of getting out there and, figuring out what works for you. Extra clothes we already talked about, and headlamps. And I say lamps because, again, going back to that idea of that 2 is 1 and 1 is none. If I have 1 headlamp and it goes out, I have 0 headlamps. But if I have 2 headlamps and 1 goes out, I have 1 headlamp. This has happened to me more times than I can tell you. It's either happened to me or it's happened to somebody in my party where I've given out my second headlamp. So always consider having 2. The other thing I always do is I make sure that that headlamp lives in the same pocket every single time I go somewhere. In fact, I never unpack my headlamp when I come home. I leave it in the same pocket because if I need it, I need to fumble around and get it. I want to know exactly where it's at and I can get to it quickly. So medical kit considerations. I love this topic so much and I can talk about this forever, but really it just comes down to kind of grouping these items and using what's going to work for you. So we've got the prevention items, sunscreen, bug spray, sunglasses. If you get so sunburned that you get sick and you have to stop a trip and everybody has to go home for you, they're not going to be very happy with you, right? So you need to prevent these things from happening. Bug spray, everything in the world bites me. I always have bug spray. It's like my perfume. Sunglasses you need to wear, you need to bring with you in every environment. I don't know if anybody's ever had snow blindness, but it's incredibly painful and that patient really is blind. You have to evacuate them and they can't see, which then sets them up for being at risk for other injuries. So sunglasses, just basic, simple stuff to bring with you. So prevention is the first category. Pain meds, of course, I always take a lot of pain meds with me. Make sure that you're using them judiciously and you're not over giving them to patients, like somebody who might be dehydrated, that might be at risk for renal problems. So make sure that you're using them appropriately. Antibiotics, we kind of touched on a little bit earlier. I'll give you a couple resources at the end here. Know where you're going. What are the pathogens that are endemic to the region that you're going to, right? Are you going to be on a river that's got nothing but crypto in it? Or are you going to be somewhere else where you know that they've got virus in their watershed? Or are you going to be in another country to where they have nothing but, dengue and everything else? So I look at where I'm going. I look at what is the likelihood that I'm going to be exposed to that pathogen. And then I get the antibiotics that I think I'm going to need to take with me. Wound care. This I can't tell you, you will never have probably enough wound care on you. Blister care is paramount. So blisters and GI problems are the top 2 reasons for adventures to be stopped and halted. And these are two things that can be prevented. I use Metapor tape. It's commercially available. I don't work for 3M, but it's what works for me. I've done a lot of ultra marathon, and I volunteer as medical for ultra marathon races, and I do nothing but blister and foot care, and I use this Metapor on these ultra athletes all the time. Blister care is a whole nother topic. But yeah, if you need to, you want to not that person that has to stop a trip because of blisters. That's going to be rotten, and no one's going to be really happy with you. If you get a hot spot, stop, take the time, address it, and then you'll have a great trip. So blister care is huge. Again, SAM splint, please go onto that YouTube for SAM splints and look at all the things that it can do, because it's pretty cool to have one. Ace wraps, of course. I always keep one in my bag because it can be used for everything, even hanging stuff out of a tree. It doesn't have to be medical, right? KT tape can be used to address sprains and strains, and also can be used as blister care. So as I'm talking, you're probably getting, the theme here, that when you're taking something or considering something in your pack, that you should consider what else can it be used for. Duct tape, and safety pins, right? Those can be used for everything. So you really want to try to consider stuff that you can use for more than one thing. Personal meds. EpiPen is what I always have with me. I have anaphylaxis to things. I learned this lesson. I was in a village in China, and I had an allergic reaction to an antibiotic, and my mouth and lips swelled up, and I didn't have an EpiPen with me, and they only had Eastern Chinese medicine and no Western medicine available. So that was a valuable lesson for me. I know that this is always kind of one of those ethical questions I get, should I get an EpiPen from my provider if I don't have any anaphylaxis? If you're in the outdoors, you're with somebody that goes down from a bee sting and you watch them die. Ethically, for me, I'd rather have the EpiPen on me. So I'm not recommending it. It's just something that I have with me because I do have anaphylaxis. Procedural tools, are you going to expend that weight? Are you going to carry that extra weight? Do you want to bring suture material with you? Do you know how to suture? Is it something that you would provide as a skill? I bring mini scissors and tweezers. Tweezers are great. They work for everything. And then I also bring a little pocket rescue mask. You can see at the bottom right-hand side of the slide here, it's called NU mask. It's NU mask. It's a tiny pocket device. It's smaller than those other devices that slips into the patient's mouth to provide CPR. And then you blow into the end of it. It's got a one-way valve on it. And it also hooks up to a BBM, which is really helpful and super easy to use. Right, so we already kind of touched on this. These are the things you have to consider when you're building your kit. Where am I going? Is it going to be hot? Is it going to be cold? Is it going to be hot during the day? Is it going to be cold at night? Am I in the desert where it's hot and it's 20 degrees at night? What activity am I going to do, right? And what are the most common injuries? So I have a different kit when I go out mountain biking, because the most common injuries I know of are going to be probably wrist injuries, dislocated shoulders, knocked out teeth. So I bring actual emergency dental kit with me. And pain meds, right? If I'm skiing, I have a whole different set of gear. So it's really like I've got these little bags that I actually shove into other bags that I've built. That way I'm not always constantly repacking stuff. And again, look up what the most common endemic pathogens are in the area. And that way you're prepared just in case you've accidentally ingested those. Talk to other people who've been on trips that are similar to yours. Find out what worked for them, what they wish they had brought with them, what they wish they hadn't brought with them. Were there any accidents? How did they handle those accidents? And just really just like get into the nitty gritty on that. And there's tons of blogs out there and podcasts and things that you can actually just research yourself. Right, more things to consider. Consider having different kits, like I said, for different activities, right? I'm up there ice climbing and then I'm down there in the desert. I'm not probably taking the same kit for those two places. Those are two totally different activities that are going to have different injuries. Everybody on the trip carries their own medical kit. If you are going to be the medical provider, you are not going to be the mule carrying all that medical stuff. For example, we had some guys that were out on a hunting trip. The guy that was carrying all the medical kit, he fell down a ravine and his backpack got ripped off halfway down that ravine. He broke his femur. He had a punctured lung, hit a pneumothorax, and multiple lacerations. And his kit was halfway up the ravine and the other guys couldn't get to him. And then they didn't have any medical stuff. So everybody carries their own medical gear. Even little kids, give them that responsibility of carrying their own Band-Aids, carrying something. Just so everybody has something on them. Keep your kit in the same place as you always do, right? In your bag or your car, and make sure that it's easy to get access to. I keep my medical kit on top of my bag. I know exactly where it's at. I can unzip it and whip it right out. and I can render aid much more quickly. So we're talking about doing your research, okay? I go to all these amazing places, right? But I look at where I'm going and what's going to happen. So here's a couple of resources for you. Travel.state.gov is a great resource. One of the things you certainly need to consider that I always look at, especially international travel, sadly now it's probably domestic travel is there political unrest going on? Is there some sort of emergency or danger that might be facing me that I'm not aware of because I don't live in that country? Especially as the single female that travels, it's a really great resource. I can look that up and figure out, is this a safe place for me to go? I signed up for the Smart Traveler enrollment program on that website. That hooks you into your embassy that's local to the country that you're going to, so they know that you are there, and they know where you're going to be. So if something happens, they can help to get you out of that country. CDC Travelers Health website. I love this website because you can put any country into the bar and click on it. It pops up all the vaccines that you need for that area. It pops up the diseases that are current and active in that area. So like put in Costa Rica, tells you all of the vaccines, tell you that dengue is going on, Zika is going on, the things that you need to consider, right? Antibiotic wise, what you might take with you. So it's a great website. And also CDC has this global water sanitation and hygiene website. It's got a great resource and it talks a lot about hiking and hikers and how to treat water and things like that. And then it's got some other resources. So I do love those resources too. Right, so we'll kind of end talking about the wilderness nursing resources. Like, how do you get into this, right? And it's so exciting to cross your passion with your profession. So ways to get involved, again, we talked about this, the Wilderness Medical Society, that's WMS.org. For participants for this webinar, if you use the code WMSRN, you're gonna get 20% off your first year's membership. I implore all of you to at least take the time to go and look at this website and look at the resources they have. It's incredible and it's changed my life. Join the WMS Facebook page. It's really fun. They have a lot of different things on there, including patient scenarios. They have opportunities for free educational learning like podcasts or fireside chats. They'll put up some scenarios, things like that. It's great. AWLS.org, so that's Advanced Wilderness Life Support. That's a 2.5-day class. It's actually the class that I teach. And instead of me quickly blabbering on about this within an hour, you get to sit with me or other providers for 2.5 days and learn a lot of other topics and also practical skills and things like litters, carries, dislocations, all of that. It's a great start. This is also NOLS as well. NOLS provides these classes, the WOOFer, the WUMP. Just getting out there and getting yourself educated and seeing where it can take you. It's a great way to network and get involved and see what other people are doing too. Included here, I think Kelly included these clinical practice guidelines. Take a look at these. He almost only didn't get to talk about hyperthermia, but that's a great one. Hypothermia has got some really good, I think, infographics. Like I love this infographic's great. It's about how to use and treat hypothermia. It's very quick and easy. And then it's also got its like little algorithm in there. So that's on that hypothermia one. And earlier, I think there's a gentleman named Ross that asked about relocating the displaced ankle. Yeah, take a look at that one. And I think you guys are going to get a lot out of this. All right. That's what I got for you. I hope that you enjoyed and learned something today.
That was fantastic. As a former ER nurse myself, I was just like, oh, this brought me so much joy. Because you see those things in the hospital, but you're like, what do you do if you're out there in the wild, actually? So thank you so much. I don't know if anyone was checking out the chat, but Kelly George from the Wilderness Medical Society dropped a lot of great tidbits in there. And we are going to be sending out all of those links after the fact in a wrap-up email, which will include a recording of the presentation. But again, Cory, you were fantastic. This was such a great presentation.
And I love this. So you can always ask me to come and talk about this.
Oh, perfect. Well, we'll definitely do that. And everyone should probably wish Cory a happy birthday.
Thanks.
Does someone have a last question?
Yes. Jamie, I just joined because I was having the hardest time even figuring out how to join this. Like, it was not working for me. So I missed the whole darn thing.
That's totally fine, Jamie. We're going to send out the recording as soon as we get this all cleaned up. So you'll actually receive the recording in your email.
Oh, thank you so much.
Yeah, no worries. It happens all the time.
Just something I really wanted to see.
Yeah, absolutely. We'll send it out, and we're going to send it out with Cory's and Kelly's contact information. So if anyone has any questions, feel free to reach out to them or us at Trusted Health. We're happy to help. And we will be sending out a follow-up survey as well. If you'll please complete that and let us know if you liked it and what else you'd like to learn about. That's super helpful for us here at Trusted Health and the WMS. So thank you to Kelly from the Wilderness Medical Society, Cory, and everyone for attending. And we will see you at the next one.